and welcome to this video of cataract surgery in a patient with pseudoexfoliation. This is an uncut teaching edition so that you can really appreciate the flow and timing of the surgery. I always start with the temporal groove that I make freehand, and then we'll add the biplanar entry later and paracentesis using the same knife. So then we can get started with a little viscoelastic. This particular eye has actually pretty reasonable dilation for pseudoexfoliation, so I didn't need to do any special pupil maneuvers, though I never use rings or stretching techniques, especially with pseudoexfoliation, because these the iris is really pretty delicate in these eyes and will often get into trouble. So here's the biplanar wound to get started, and then the technique that I use is pretty standard phaco chop. I've modified it over the years so that I can pretty much do the same technique every time. So there you see the 5mm, 5.5mm rexus goal here. The forceps have a little mark on them, and in this particular case I do it in multiple steps, and what I'll do is I'm doing this because I'm getting a decent amount of movement from the patient, and if I think the person's likely to move, I'll try to do small little curves instead of taking a nice big swipe at it. If they're steady as a rock, then yeah, it's great to go around in like 3 grabs, but when they're a little antsy and moving, I'll take multiple little bites just in case. So here we go with the Chang cannula, and there was one of our movements. So with the pseudoexfoliation eyes, especially, I go really delicate with the hydrodissection. Try to do just a little bit, then a little bit, then a little bit. One big blast fluid wave in these eyes, and it's very common for the posterior capsule to rupture. So I just don't want to cause too much disruption. I'm just kind of hitting it with just enough to kind of get it back there and tap it down a little bit, and kind of roll around the cortex. I'm not really trying to rotate the nucleus here. I'm just trying to loosen up the cortex in the front and make sure there is a little bit of rotation. There's some evidence from studies that rotating causes more stress on the zonules, so I just try to leave it alone as much as possible. And then I go in and do a basic cleanup of all that cortex that I just fluffed up so I can get a really good view, because I usually prefer a horizontal chop in pseudoexfoliation. So here I go, bury the tip in and then bring the chopper all the way around. This is a Nickerman chopper. It's been my favorite for many years, and this is very low stress on the zonules. Keep all the forces going from the chopper to the phaco tip. Once the piece is loosened up, then it can just be brought to the tip and removed without really doing a lot of manipulation. I really try to just break stuff up and bring it in. So you can see there, it's not a lot of pieces flying around. I certainly don't like doing like a rotation for like a 4-quadrant stop and chop, or some people will rotate everything and chop all the way around before doing any removal. So I don't like doing that in pseudoexfoliation. I really prefer just to do just the bare minimum, get the piece free, and remove it. And so you can see it was really gentle, not a lot of stuff. So here's the handoff, because again, this patient moving around, a little antsy, was doing a little breath holding, trying to work through it. So I do the handoff maneuver. So I put the viscoelastic in, and now I can keep the chamber nice and stable so I don't get chamber collapse. I think that's especially important in these pseudoexfoliation eyes. So we'll go in with the IA and just do basic cleanup. There's really nothing exotic about this technique, just some very minor modifications, and then I go slow and just really take my time, because these eyes just have a real tendency to go south really fast. So I always treat a pseudoexfoliation eye with extra care. Not that I'm cavalier with other eyes, but there's a lot of stuff you can get away with when it's not pseudoexfoliation. So here we have everything ready to go. Going to do the final little cleanup polishing with the shepherd polishing rings. I still really do like polishing the capsule. I know it's not done by everybody, but I feel it keeps the lens system more stable post-op. You don't get quite as much fibrosis, and I think our numbers show that we get very stable refractions and predictable refractions. So we put the standard lens in. This is an SA60 AT lens. Deepen the chamber a little bit first, because I do like to keep it a little shallow for the polishing, so that sometimes I can get at the posterior capsule, and then I'll deepen it for the lens. And my new favorite technique is to put the lens in and then go back in with the IA. And what's hard to appreciate here in the video is when the IA goes in, I'm going to hit the irrigation, and that actually deepens the chamber and kind of floats the lens in. It actually almost goes in by itself. I'm not really doing too much most of the time, but if I have to, I can just kind of rotate that tip and it'll just push it right back in there. So it's really efficient technique. It eliminates the need for like a Kugelin or something, and you need the IA in there anyway if you're removing viscoelastic. So that works out great. And then pretty standard cleanup. I really, I do try to clean up pretty thorough in every case. Nothing special there about pseudoexfoliation. And we've got an interesting feature here coming up that is fairly special. There it is. Look at the arrow. So little iris prolapse as I came out, and that's just so common in these eyes. The iris can be so floppy, and then it starts to bleed. So that's the whole reason I don't ever stretch or put rings in a pseudoexfoliation eye. These eyes, just that tiny little episode of prolapse, the thing's starting to bleed now, and I had a little bit of problem because we had a little bit of anxiety and breath holding at the very end. But otherwise, that's it. That's a pretty standard phago chop case for a pseudoexfoliation eye. Really not a lot of modifications, just a couple things to be careful of. And these cases can be quite successful most of the time. One last little bit of BSS to stabilize the chamber, do a little bit of breath holding, and that's all there is. And thank you very much for tuning in.